whenever we think about diagnosis, always ask for all the views. Now, if you see this this picture of the prince, he is abusing someone. However, if you take a proper AP view, he is asking someone something. So these are the importance of AP and lateral views. So what are the views, types of views we need to take into consideration? So the type of views we need to take into consideration are PA view, AP view, lateral view, and oblique views, which are all special views. So how do we take a PA view of the wrist? It is a zero rotation view of the wrist. The shoulder should be abducted up to 90 degrees and it should be parallel to the ground. The elbow should be flexed to 90 degrees. So how do we realize that this is an AP PA view? Is from the styloid process of the ulna. So styloid process is on the ulnar side. This means that this is a true PA view of the wrist. Also, the distance between the carpal bones is less than 2 mm, and always look for the Gilula's lines. So in this case, you see the Gilula's line in the proximal part of the scaphoid, lunate, and the tracheotomy. Then the second Gilula's line is along the distal part of the scaphoid, lunate, and the tracheotomy. And the third Gilula's line is along the capitate and the hamate. So these all things should be looked in a proper PA view. AP views are also important. So AP views normally we take to look into the Gilula's lines, and also you note that if it is an AP view, the styloid process of the ulna is little bit radially. Zero rotation lateral view of the wrist. This is another important view which is needed to be taken for the wrist. So shoulder should be adducted like in this picture, and elbow should be flexed to 90 degrees. Now in this view, we locate the DRUJ, position of the carpus, and for the carpal injuries. Note that the position of the pisiform is very important in case of a true lateral view of the wrist. So what happens in a true lateral view is, according to this paper by Goldfarb in 2001, he says that the ventral cortex of the pisiform board should be between the ventral cortex of the distal pole of the scaphoid and the head of the capitate. So in this case, these three views are acceptable views. However, these two views down here are unacceptable views. So this is the true lateral view of the wrist. Now there are again, so this is a case which suggests there is some abnormality in the carpal bones and there is a fracture of the radius. So what you see normally, which is significant, is the fracture of the radius, and you go and plate it and you forget the other things. So look at the Gilula's line. The Gilula's line are broken and the capitate is inverted. Always take a lateral view in all cases. In lateral view, again, you see that the DRUJ is subluxated. So this is a Galeazzi type of fracture, and the capitate is inverted. So, and also there is a scaphoid fracture. So this is a case of scapocapitate syndrome. Again, there is some disruption in the Gilula's lines, but this might be, if there was only a PA view available here, you might just forget it. Again, now if you see the lateral view, you see that there is a perilunate dislocation. On the X-rays PA view, you see what is called as the the avascular necrosis of the scaphoid bone. So this was confirmed with MRI later on, but you have to suspect these diseases of the carpal bones. Also, the diseases of the lunate and other things like Kinbox disease can also be found out on PA views. So now this is the lead lateral view of the wrist. This is mainly for the distal and radius fractures. So you have to tilt the wrist to about 11 degrees, and you see the standard lateral projection here down, and what do you look here is the lunate fossa and the teardrop. Also, you have to look for the projection here, which is the radius, the radius. The AP view, so the PA view of the wrist and the lateral view of the wrist. Always look for the radial inclination, radial shortening, and the volar tilt in case of lateral view. And here you can see the teardrop and the teardrop angle. If you have done a surgery in the lateral view, you have to look for these signs as according to the Song's criteria. So this is the critical line. So if the plate is projecting across the critical line, that means that you can irritate the flexor tendons. So this is in an acceptable position. However, this X-ray and the another X-ray, I have to look for the flexor or FPL tenosynovitis. And if the patient is having tenosynovitis, I will have to remove the plate early. So always look for this projection in the lateral view, and look if it crosses this projection, that means you have crossed the watershed line, and there might be a irritation of the flexor tendon. So oblique views are very important for the wrist and the hand. So hand rests on the ulnar border and it tilts to about 45 degrees in a volar direction. The scaphoid, triquetrum, body of the hamate, scaphotriquetral, and the trapezium trapezoid joints can be seen properly in this view. Fourth and fifth CMC joint also can be seen in this view. Ulnar deviated views are very important to note the complete anatomy of the scaphoid. So the deviated view in 20 degree of ulnar deviation is a scaphoid view. However, always give a little bit of extension to the wrist. So this may help in improve visualization of the scaphoid. So this is called as a PA ulnar deviation view of the wrist. So these are the X-rays which are needed for a scaphoid series. This is a PA view. You can see that the bone graft here, there is a bone graft here. However, there is no union seen properly. This is the scaphoid view with 30 degrees of extension. Now in this case, you can see the entire anatomy of the scaphoid, and there are signs of union. Pronated view, you can see the entire length of the scaphoid, and the lateral view to note if there is any humpback deformity or any other problem with the scaphoid. Clenched fist views are special views which are needed mainly for scapholunate dissociations. Always compare clenched fist view with the opposite side. A scapholunate interval greater than 4 mm, as in this case here, can be a suggestion of a scapholunate instability. Also note that there is a signet ring sign of the scaphoid. So this is a foreshortened scaphoid because of the hyperflexion of the scaphoid in a scapholunate dissociation. If there are hook of hamate fractures, mostly in bicycle, those who ride bicycles get this type of fractures, or on injury on the ulnar side of the palm. So in this case, the hand is maximally extended and volar surface of the wrist rests on the cassette. The central beam is directed towards the palm at 15 degrees. So this is a very important view to note the hamate. So this is the hamate and this is the pisiform. Supine, oblique, and the ball catcher's view. These are two important views which can be interchanged actually. So ball catcher's view is it is like a position of catching a ball. So in this view, this is a type of supine oblique view only. You see mainly what is called as a pisotriquetral areas and compare it with both the sides. So you can see if there is any pisotriquetral arthritis. So this similar type of view when you take for a single hand. So in this view, you can see the head of the metacarpal and the head of the metacarpal, and it is used for pisiform, pisotriquetral arthritis, and metacarpophalangeal joint. So these are the views which are mainly used for metacarpal fractures, are prone oblique views, PA views, and a supine oblique view. Specialized view for metacarpal head subtle fractures is a Brewerton's view. In this case, the palm is flexed at 60 degrees and an X-ray beam is passed through the metacarpophalangeal joints. You see this type of view, and it is mainly used for the subtle fractures of the metacarpal head. Metacarpophalangeal joint arthritis also can be found out on these X-rays. Lateral view of the thumb and the CMC joint can be made by making hand pronated to 20 degrees and thumb flat on the cassette. So in this case, you can see the lateral view of the thumb, and the CMC joint arthritis can be visible very clearly in the lateral view of the thumb. PA view of the hands and finger, the hand is fully pronated and digits slightly separated. So single digits also can be found out. Single digit X-rays can also be taken by this type of view. So if you see this X-ray, you can see that there is a tuft fracture. This is a single digit of the digit X-ray of the hand. In this X-ray, there is something abnormal in the PIP joint. However, you need to confirm it with a lateral view. So lateral views are necessary in all the finger fractures or any finger condition. So this is a true lateral view. So this is the way you take a true lateral view. The hand is in lateral position, and thumb side of the thumb side up for third and fourth digit, and thumb side is down in case of second digit. This is not a true lateral view, which we usually get in our clinical practice, and the patients come with these type of X-rays. If you note these two X-rays, you can see that there is a fracture here. However, when you take a true lateral view, you find that there is a fracture dislocation of the PIP joint. Oblique views of fingers are also important to find the position of the fragment and the injured area. So in this case, you can see there is a subtle fracture in a true lateral view. Prone oblique and supine oblique views are done to note that where is the fracture. So you can see that there is a fracture on the radial side. Again, there is a fracture on the radial side here. So finger views, again, PA view, oblique view, and a true lateral view is very important to note the exact anatomy and the type of fracture. This is a type of mallet fracture. So you need to know, you find it only on true lateral view. So to conclude, scaffold series, we take PA view, scaffold view, prone oblique view, and lateral views. Carpal bones can be found, carpal bone abnormalities can be found by PA, AP, true lateral, prone oblique, and supine oblique position. Distal radius fractures can be very well found out by PA view, tilted lateral views. Metacarpal views are like PA view, supine oblique views, which focus on the metacarpophalangeal joint, and a prone oblique view. Pisotracheal arthritis can be found by a ball catcher's view. Subtle metacarpal head fractures by Brewerton views. And thumb and CMC joint views can be found by the Roberts view and the lateral view. Finger, all PA and lateral are very important. However, oblique views are also important to mark the fragment position. Thank you.